everybody. Dr. Alhami, thank you for your introduction, and I would like to thank organizer for inviting me. I'm super excited to be here. This is my second visit, and the first one was the beginning of pandemic, so it didn't count really. I didn't have a chance to interact, but the best I get out of this kind of meetings is networking, interaction with you guys, learning a lot from doctors from different countries, and finding new friends. So thank you for including me. So I'm going to talk about, I call them NuSH-based therapy or nutrient-stimulated hormone-based therapy, and cover new frontiers, new treatments for obesity, and also talk a lot about what we have in pipelines. The frustration, I know up front, I will tell you that we all have it, even in the US, that a lot of these medications are not covered by insurance. But I think it's very important to know the science, learn the science, and keep fighting, trying to convince our partner insurance companies that these are really helpful. And we keep talking about what Dr. Hani said. We want to cut the problem from the root causes. So here are my disclosures. I do a lot of clinical trials, so I have interacted a lot with different companies, especially those ones that are in the kind of field of making GLP-1 receptor agonists or other incretin-based therapies. We heard a lot from Dr. Mariam about the prevalence of obesity here in this part of the world and global incidence and prevalence. I'm showing you just one slide that US has very similar problem. This is the information about the prevalence of obesity defined by BMI of more than 30. So let me make sure it works here. Yeah, this shows BMI more than 30 from 2000 or 1990 up to prediction in 2023. And the darker color shows higher prevalence of obesity. And I'm from Colorado. Colorado was always the leanest state in the United States, and the prevalence of obesity even is going higher in all states, especially in the southern part of the United States. The prevalence is going to, even by 2030, more than 50% of people are going to have BMI more than 30. And maybe 1 out of 4 will have severe obesity defined by BMI more than 35. So increased prevalence of obesity is a global problem, and US is not excluded. So you heard a lot about previously in previous talks about complications of obesity is not just obesity and high BMI. What we are worried is all the comorbidity associated with obesity. So I decided to start my presentation with a case that all of you have seen such a patient, and I would like for you to interact, and if you have any comment or question, feel free to talk. So this is a 62-year-old female presented with shortness of breath on exertion, fatigue, irritable mood, and problem with focusing. Probably you've seen a lot of patients like this in your office. Medical history, TIA at age 58 that completely resolved, osteoarthritis of the knee, hypertension, dyslipidemia, hypothyroidism, and prediabetes. You see the list of medication, some blood pressure medication, statin, and aspirin and levothyroxine. On exam, BMI is 34, blood pressure is not bad, 130/76. There is 1+ edema in lower extremity bilaterally, and A1C is in pre-diabetes range. LDL, maybe you want the target of less than 70, but she's on 78, triglyceride is okay, and the rest are also okay. Patient has done echo about a month ago, and ejection fraction was 55%. What do you think about this case? With all of the presentation and information that Dr. Hani gave you just half an hour ago. So when you have such a patient, the main problem now is shortness of breath, fatigue, irritable mood, and problem with focusing, lower extremity edema, prediabetes and obesity in a female. I think what you need to think first is HFpEF. Dr. Hani mentioned the consensus of ADA and AHA in collaboration with AHA. Actually, I was one of the co-authors, and we mentioned that in everybody with metabolic and obesity, metabolic syndrome and obesity, you need to think about HFpEF. It's very prevalent, maybe more in female than male, but we myself are also guilty of, when obese person comes to your office and complain of shortness of breath, we blame that a lot on inactivity. You haven't exercised, you are fat, and that's the main reason for shortness of breath. But it's very important to think about HFpEF, think about other comorbidities. Another thing that I want to bring to your attention, get missed frequently, is sleep apnea. OSA is another complications of obesity that we need to think about it. We need to test that to diagnose. And a lot of patients just come with a fatigue, and it can be a common presentation, and you don't think about it. So as it was mentioned, probably all of you have this problem too, telling patients that all of the problems is due to your obesity. At least in my practice, most of the patients don't want to hear that. When they come with a problem of shortness of breath or fatigue, they say, it's because you're obese. Or the other thing is, it's all your nerves, or you have anxiety. These are the two things patients don't want to hear. But how to talk about this, I call it the elephant in the room. We saw that the big root of the tree that you have, so I put it as an elephant in the room that people know, but they don't want to talk about it. So how to talk about obesity? Dr. Mariam mentioned motivational interviewing is very important, how you start your conversation about obesity. I follow this 5A approach. People use that for a smoking cessation or for obesity, but that's something that to consider in your practice. First, ask patient, ask for their permission. Is it okay to talk about your weight? You know, just opening with that statement, it makes a huge difference, rather than starting with a statement that you're obese. This is the main problem. You know, ask them, is it okay to talk about your weight? Assess all the comorbidity associated with obesity. A lot of patients, they have those comorbidity, but it's good to go over them one by one and see what comorbidity that a specific patient has. Advise them on lifestyle modification and talk about pharmacotherapy. And it's very important, changing the mindset of patient. You need to make sure that your patient agrees with the plan, agrees with your assessment, and setting up a SMART goal. And that kind of is mnemonic, stand for specific, measurable, achievable, relevant, and time-bound goal. As simple as, you know what, for your lunch break, maybe go for a 15-minute walk every other day. Make it specific, because it makes a huge difference, rather than telling patient that you need to change your diet and do physical activity. And assist, sometimes helping patient by doing more supportive care, including follow-up with dietitian. We have some dietitian in the audience, and behavioral therapies. It makes a huge difference. It was mentioned that we, as a physician, we cannot kind of provide all of the counseling on diet, and we don't have the expertise on diet, behavioral therapy, psychotherapy, so you need to get help and use your resources. So in this specific case, we sent patient for further evaluation. Actually, she was diagnosed with HFpEF and didn't have OSA or other complications of obesity. So we decided to come up with a life-based therapy first, as a first stage. That was one of the questions, that should you go with a life-based therapy, lifestyle changes first, or start medication? You need to talk to your patient. You need to find out what is the best approach. In this case, we talked to our patient and we said, let's try lifestyle modification, diet and exercise, behavioral therapy, and we set a target of 10% weight loss until the next visit 6 months from now, and also encourage more physical activity. Patient comes back 6 months later. What you see commonly in your cases, typically they don't lose that much weight that you recommend. That's the frustration we have had as a physician, as a patient. It's difficult. It's difficult to lose weight. There are many patients that are very successful. I'm not debating that fact that lifestyle modification is important, the foundation of treatment, and you need to promote that, but the rate of success is not that high. So this patient comes back, loses 5%, which is great, we congratulate her, but still she complains of shortness of breath. And what you should do now, we talk about continuing lifestyle modification or starting pharmacotherapy. And patient agrees to go to pharmacotherapy and thinks that I'm going to continue my lifestyle modification changes I have made. I'm going to continue exercising, but at this point, I'm ready for pharmacotherapy. And let's hypothetically say that wherever society or country that this patient lives, the pharmacotherapy is covered, because that's another layer of complexity that you want to start a medication, but it's not covered, and then you need to think about financial burden. One of the audience mentioned that the cost of this is way more than utility. I mean, if a patient has to choose between paying electricity bill versus paying for medication, I'm sure they're going to choose for utility bills. But let's hypothetically, for the purpose of this talk, consider all of this medication covered by insurance. These are the list of the medication that at least FDA approved. They are approved in the US for prescription with the purpose of obesity treatment or weight management. We have phentermine, which is a sympathomimetic medication. Is approved for a short period of time. It suppresses appetite, but is contraindicated in patients who have coronary artery disease, tachycardia. Next one is orlistat. You might have it here, that this one has a lot of GI side effects because it blocks GI lipase and it prevents absorption of the fat. Next one, because this rapid release phentermine had a lot of complications or side effects, we have slow release phentermine combined with topiramate together and with the brand name of Qsymia. The weight loss is better than previously mentioned drugs. It's up to 10%, 5 to 10%, and it has some side effect of phentermine, but also has insomnia, paresthesia, and it's very important not to prescribe to women, childbearing age women, and if you prescribe it, you need to do frequent pregnancy testing, and for sure some sort of contraception is used. The next one is naltrexone bupropion with the brand name of Concave. I don't know if you have it here or not, but this one is also has a weight loss of just 5%, and the naltrexone is opioid antagonist, and it decreases that craving for the food. So that's another option. But for the purpose of today's talk, I'm going to focus on incretin-based treatment. And we have 3 of them that are approved for management of obesity: liraglutide, semaglutide, and tirzepatide. And you see the weight loss is going for most of them above 10%. We had a nice data that was shown by Dr. Mariam that you need at least about 10% weight loss to see clinical benefit. So all of those previous medication that we had, most of them caused weight loss of less than 10% with a lot of potential side effects. So let's talk about incretin-based therapy. Just to give you a very short background, what is incretin effect? Probably all of you know here, we heard about incretin a lot. As endocrinologists, I'm super excited about this kind of field. And you know as a fact that glucose stimulates insulin secretion. But back in like 1960, we learned that if you give glucose through oral ingestion, you see some insulin secretion. But if you give glucose through IV route and create the same level of glucose level in the circulation, insulin secretion is significantly less. This red one is the response of response to glucose and insulin level through IV glucose, and this is for oral. So there must be something coming from GI system that stimulates insulin secretion. And it's not just glucose level stimulating insulin secretion, because in both experiments, they had the same glucose level. That's why they call it incretin effect. And this is as opposed to excretin, something from GI that stimulates enzyme from pancreas that helps with the digestion. This is incretin, something from GI system that stimulates insulin secretion. So what are these incretin factors? We learned after a couple of decades that there are some peptides released from small intestine. They call it specifically L cell. They make a peptide named glucagon-like peptide. The half-life is very short because we have an enzyme, DPP, that degrades this peptide and inactivate that. But what is the role of this peptide? It stimulates insulin secretion, blocks glucagon secretion, it slows down gastric motility, and also it suppresses appetite and satiety. So this pathway has been the target for pharmacotherapy mainly, or it started with diabetes treatment. If you make GLP analog, or if you block this enzyme that inactivates GLP, you can improve blood sugar by stimulating more insulin, decreasing the absorption of glucose, and also suppressing appetite. So we have almost 6-7 GLP-1 analog that is FDA approved. Some of them are short-acting, once a day, like exenatide, liraglutide, or lixisenatide. Some of them are now weekly medication, like semaglutide, and we talk about tirzepatide, which is actually a dual agonist. But for the purpose of obesity management, there are 3 of them now is approved for treatment of obesity, which is liraglutide, semaglutide, and tirzepatide, with the brand name of Saxenda. And for semaglutide, Wegovy, and tirzepatide, we have Zepbound. Mounjaro is for diabetes management. At least in the US, it's distributed as Zepbound for obesity management. I'm going to bypass the cardioprotection data because it's going to be talked a lot, but showing you the data on weight loss for these 3 medications. The first one is liraglutide. Scale trials show that liraglutide 3 milligram per day caused about 10% weight loss in people without diabetes. Just editorial comment here, people without diabetes usually respond better to this medication compared to people with diabetes. We don't have a good explanation, but whatever weight loss you see in non-diabetic people typically is better than what you expect with people with diabetes. So it was 3,700 people, age of 45, 78% women, and they lost roughly about 8% if you especially subtract the placebo effect. Then we have semaglutide once weekly up to 2.4 milligram, and the STEP program evaluated the effect of semaglutide in obesity. Again, in step 1 that I'm going to show you more detailed information, it was in non-diabetic people. More than 1,000 people were randomized to semaglutide versus placebo. They were followed for 68 weeks, and the age was 46, BMI 38. It happened to be almost identical to previous study. And the weight loss effect was over 10%, closer to 15. So I put these 2 trials next to each other to get an idea that you will see that semaglutide once weekly is more effective than liraglutide daily on weight loss. And the lower one shows the percentage of people that lose certain amount of weight. And let's focus on 10% weight loss because I like to choose 10% as a kind of clinically meaningful weight loss. And 75% of people on semaglutide, they lose at least 10% of weight. But in liraglutide, it was only 33%, 1 out of 3. So you will see this slide a couple of times throughout my talk to kind of compare the weight loss efficacy or weight loss effect of different interventions that we have. We talked about bariatric surgery being the most effective one, going over 20% weight loss depending on the type of the surgery. Then we have lifestyle modification that typically people lose 5% or less and maintain it. And then we talked about different medication, and we covered semaglutide and liraglutide data. But let's go to tirzepatide. What is tirzepatide? So just to give you some base background information, is a dual GLP-1 and GIP agonist. So two different incretin, two different peptides released by intestine. They have a lot of similarity and some differences. Both of them affect satiety, so they cause suppression of appetite. They both stimulate insulin secretion and suppress glucagon. GIP doesn't have any effect on the gastric motility, but it increased the lipogenesis and has some effect on the adipose tissue. And this is their kind of the molecular structure. This is GLP-1, this is GIP, both of them being peptide, both of them are the substrate for DPP. When we have semaglutide, it's very similar to GLP-1, and that's why semaglutide is GLP-1 receptor agonist. Tirzepatide has some similarity with GIP, has some similarity with GIP, and has that blue tail at the end is exentin 4, which is kind of the GLP that we got from Gila Monster. So this molecule can activate both GLP and GIP receptor. And let's see if you activate both receptor and attack the incretin system or attack these two receptors at the same time, what kind of efficacy you see? SURMOUNT trial was the one that tested tirzepatide effect on weight loss, and more than 2,500 people were randomized to either placebo on the top or different doses of tirzepatide, 5, 10, 15, and you will see that at doses of 15, that was the highest dose, and they were followed for about 72 weeks, they got to 20% almost weight loss. If you do subtract the placebo effect, something around 15% weight loss. So again, just for comparison, technically, I mean, just keep in mind that you're comparing trials with each other, so between trials, and this is not head-to-head technically, but to give you a perspective, I put the baseline characteristic on the top, and they're very similar. What is important is to know that female typically lose more weight. So studies that they have more female than male, you expect more weight loss. And tirzepatide happened to have a little bit less female compared to the other two trials. But when you see the effect of liraglutide under 10%, semaglutide around 15%, and tirzepatide is going over 20% weight loss, so for sure more effective. But what they have in common, they are all peptide and they are all injectable medication. What about oral GLP? Because you might have patients that they don't like injection and they want to kind of consider the oral medication. I want to tell you about oral semaglutide. Again, semaglutide being a peptide cannot get ingested, and GI system, the low pH of GI system will destroy that peptide. So GLP-1, this GLP-1 or semaglutide is co-formulated with a molecule, we call it a SNAC, and this SNAC will protect semaglutide from the low pH of the stomach, so it can get absorbed. But only 1% of it get absorbed. So you need to have a lot of semaglutide in the pill for 1% to get absorbed. And the current dose for treatment of diabetes is 7 or 14%. The efficacy of this medication in pioneer studies, we looked at it, and the efficacy is not as good as sub-Q semaglutide. So it's not approved for weight loss at all because the weight loss efficacy is not good. But the good news, and it's very important for patients to take it with empty stomach, don't eat for at least 1 hour, and don't take any medication with it. And a lot of patients really don't like the whole process of not eating for half an hour, and they don't take it correctly. But what is new about oral semaglutide, it has shown that higher dose of it is still safe in regard a patient can tolerate it, and it can be an effective medication for weight loss. So there has been trial for oral semaglutide at dose of 25 and 50 milligram per day. And this is a trial showing OASIS-1, showing the efficacy of oral semaglutide up to 50 milligram compared to placebo in obese people. Again, these are all non-diabetic people with a BMI of almost 38, and you will see the weight loss now becoming to close to sub-Q semaglutide. So FDA is kind of reviewing these trials and information, and probably very soon we're going to get approval for higher dose of oral semaglutide for treatment of obesity. But what about some non-peptide medication? Can't we don't have enough chemist expert that can make some chemical that activate this receptor? The benefit is it's going to be oral, and when something is non-peptide, doesn't need to be refrigerated, distribution is easier, because the whole problem that we have about this class of medication is the cost. Hopefully, maybe we can have a better cost when we are talking about non-peptide GLP-1. And this is the new class of gliprons. We have two of them, orforglipron and danuglipron, that being studied. And let's see about the structure, and then I show you some efficacy. So this is the chemical structure of orforglipron. So it's not a peptide, doesn't have amino acid in it, and the half-life is long enough to be given once a day. And as comparison to semaglutide, you see, is totally different. So we are talking about different class of medication that can activate GLP-1 receptors. And the efficacy happened to be really good. So again, this is phase 2 study in a small population of 270 people. People were started on orforglipron, different doses versus placebo, and the weight loss efficacy at the higher dose is about 15%, very similar to sub-Q semaglutide. So this might be the future. Now we have oral semaglutide and orforglipron causing the weight loss. These are, in this side of the ladder is not FDA approved. This is all we have approved. So throughout my talk, I want to also introduce something in the pipeline. Oral semaglutide and orforglipron, they have about 15% weight loss. So I gave the title of NuSH-based therapy. Why I don't say just incretin, and why I came up with this nutrient-stimulated hormone-based. It happened that GI system actually happened to be one of the largest endocrine system in our body. As an endocrinologist, I'm interested in all of this hormone also coming from GI system. So we talked about GLP-1 coming from L cell. We talked about GIP being a target for pharmacotherapy of obesity. We have also ghrelin that stimulates appetite, that's important. We have other hormones like CCK that affect exocrine function of the pancreas. So there are so many hormones here, and also we have other hormones that regulate appetite. But these are the system, we call it enteroendocrine system, can regulate pancreatic system. You know that pancreas has some exocrine cells that secrete, for example, lipase and help with the digestion, amylase lipase, and it has endocrine part that makes different hormone. And this hormone also can do very similar to incretins, can regulate appetite, can regulate a GI motility. So it's not just incretin, something coming from GI. Pancreas, the endopancreatic system also can be important in regulating appetite and in weight management. That's why people have moved from incretin-based to NuSH-based therapy to include pancreatic hormones. So what I mean by pancreatic hormone, we know about insulin and glucagon typically, but there is also amylin here secreted from beta cell of pancreas. And for the next few slides, I'm going to focus on amylin and also glucagon, because these are the hormones that can also regulate appetite, regulate GI motility, and have some effect on weight. So as I mentioned, amylin is a peptide secreted along with insulin from beta cell of pancreas. What amylin does, it delays gastric motility. Doesn't it remind you of GLP-1? It also suppresses appetite, and it suppresses glucagon secretion. So all of this effect you expect, it could cause weight loss. Can amylin be the target of pharmacotherapy for obesity? We have a compound, cagrilinotide, which is long-acting amylin. Amylin per se is very short-acting, but this compound is long-acting, can be given once a week, and we are studying this compound either by itself or co-administered by semaglutide to see what happens. So if you give semaglutide and cagrilinotide together, so we are talking about two peptides co-administered in one pen, a pen that has two chambers, and see what happened to weight loss, what happened to A1C. So the trial that I'm going to introduce is CagriSema in obese and overweight without diabetes. Oh, I'm sorry, this is a typo. This group actually have diabetes. So we look at the A1C in these people. So this phase 2 trial is in people with diabetes, but then there is another study here in people without diabetes. So in this color, salmon color, is CagriSema effect on A1C. And then we have a semaglutide and cagrilinotide. The combination has a better effect on A1C, but CagriSema is not that much better compared to semaglutide in A1C lowering. But the effect on weight loss is very significant. CagriSema, combination of semaglutide and cagrilinotide, can cause weight loss of up to 15%. This is a phase 2 trial. So this compound is going to phase 3, and that's when non-diabetic people are enrolled to get CagriSema versus semaglutide by itself or cagrilinotide by itself compared to placebo, and the study is ongoing on DEFINE program. So this is overall DEFINE program that is looking at different population, and REDEFINE 3 is actually a cardiovascular outcome trial to look at the CagriSema to see if it can be cardioprotective or not, because combination of cagrilinotide and semaglutide can be better than Ozempic or semaglutide per se for weight loss. So looking for the more effective treatment for obesity. So we covered GLP-1, we covered GLP and GIP co-agonist, we covered oral semaglutide, and also I introduced amylin receptor. But another thing that is coming from pancreas, and it could be potential for pharmacotherapy, is glucagon. Glucagon has been a little bit confusing for us because we always learn in medical school that glucagon is stimulated or goes up in response to hypoglycemia. And even for hypoglycemia, we give glucagon injection for people for treatment of acute hypoglycemia. But it happened to be that glucagon can also have different effects. One of them, it could be appetite suppressant effect of glucagon. Glucagon also can stimulate insulin secretion, and the main effect of glucagon is on liver. So not only it increases gluconeogenesis, but it also increases fatty acid oxidation of glucagon, and it increases thermogenesis, so your basic metabolic rate goes up and increases lipolysis. So what if we make a compound like tirzepatide is GLP and GIP? What if we have a compound that can stimulate both GLP-1 and glucagon? What kind of response you get? And this is again in pipeline with a new class of medication, like I call it dutides medication, that it could be pemvidutide, survodutide, and some others that they don't have even name, and they are in phase 2 and phase 1. So they are very early, but just to let you know that dual GLP and glucagon also are coming. But the most exciting one is GLP, GIP, and glucagon agonist, one peptide that activates all three of them. So I talked to you about all the good benefit of GLP-1. We talked about GIP, and we have seen in clinical setting that tirzepatide that activate both GLP and GIP is way superior than GLP-1 agonist. But what if you can also activate glucagon at the same time? And this is the peptide, very similar size to semaglutide. We call it retatrutide. Retatrutide is agonist for all three of them. It happened to be more potent for GIP than GLP and glucagon. The same with tirzepatide. Tirzepatide activates GIP more than GLP. So this molecule activates GIP, or it has more potency for activation of GIP compared to other one. But what is the clinical effect? What is the outcome? You kind of want to see what is the weight loss effect and A1C effect of this. So this is the trial, phase 2 trial on retatrutide in non-diabetic patient, and I'm going to show you the primary endpoint of weight loss. So again, more than 300 people, a smaller study because it's only phase 2, with BMI of 37. When I put these slides together, they all have the same average BMI of 37, average age of 48 in all of this weight loss trial. 48% female, and this is the different arms for a study. And the weight loss here goes over 20%, getting close to 25% in 48 weeks. And it hasn't plateaued yet. So in longer term studies in phase 3, I anticipate to see even more weight loss if we go to 62 and 70 weeks. So talking a lot about all other cardiometabolic, these are the people that do not have diabetes, but this much weight loss caused reduction of LDL of 22%, 0.5% A1C reduction, again, non-diabetic people, and 40% triglyceride reduction. And even when you read the editorial for this one, they say that these people came with a very normal metabolic status. Their LDL triglyceride was in normal range. So we should expect even more improvement on these metabolic factors for people who start with a higher number at baseline. And drug discontinuation rate was very similar to GLP-1. So this compound should be tolerated similar to GLP-1 receptor agonist. TRIUMPH program is a phase 3 program. So phase 2 was so successful that immediately phase 3 got started. And all of this trial, I'm fortunate that I'm part of the trials, and I kind of know the medication, kind of have a feel and experience with these new compounds. TRIUMPH, I mean, you will see that different TRIUMPHs, they look at different classes of obesity, and also some of them have diabetes, some don't. And these are all to be determined. They just started, some of them even haven't started. These are phase 3 program of retatrutide. So going back to this ladder, so we have all of this, again, medication approved by FDA on the right side, or intervention, let's say, because we included surgery. And retatrutide now is coming close to bariatric surgery. So for the first time, we have a medical intervention that can be very close to surgical or bariatric surgery intervention in regard to weight loss efficacy, which is super exciting. If we, again, in an era that, or a place that we hypothetically can afford and prescribe this medication, we should eliminate obesity. I sometimes say that maybe we are at a time of discovery of penicillin, that people used to die from infection. Finally, penicillin was discovered, and we had a huge revolution in medicine. Maybe we are there, and it's so exciting to experience these changes. Okay, this shows my excitement. So let's summarize the NuSH treatment and kind of move on maybe to the non-weight loss effect of this medication. So I covered GLP-1 receptor agonists. So these are monoagonists, and we have semaglutide and liraglutide. One weekly, the other is daily. And I shared with you a STEP trial and a SCALE trial. And between these two, semaglutide for sure is more effective than liraglutide. Then we have endopancreatic receptor agonists, and the main thing that I discussed was amylin analog, which is cagrilintide. By itself, it caused weight loss, but what is going forward is combination of cagrilintide and semaglutide. It's one injection, 2-chamber pen, you inject it once a week. It happened that both of them, the maximum dose is 2.4 for cagrilintide, and semaglutide maximum dose of 2.4. But I bring it several times because I don't want you to mix up that this is one compound activating two receptors. In this case, we have two compounds co-administered. And then we have other company working on other amylin agonists. Then we talked about oral monotherapy. Either we have oral semaglutide, which is the peptide just co-formulated by a snack that is absorption enhancer. But we have this exciting class of glipron. These are all chemical. I showed you the picture that these activate GLP receptor, but is not peptide. So I'm thinking about a factory that makes them. It should be much easier. Distribution should be easier. And hopefully the price should be low if it causes the same efficacy and same safety. So maybe these are the future. I don't know. Then we talked about dual agonist, tirzepatide, which is right now approved in the market, is GIP and GLP. Then we talked about GLP, and there are other compounds, none of them. So these are all dual receptor agonists of GLP and GIP, but the rest of them are not even FDA approved. They are in the process. And then we have dual receptor, but it's either, for example, CagriSema that we talked about. So dual receptor in a way that one coming from pancreas, one coming from intestine, like CagriSema, or this new class that is a GLP and glucagon receptor. We talked about all of them. And the last, but not the least, the most exciting one is this triple agonist. So this is kind of showing you all of the kind of NuSH-based therapy in one slide. So going back to this slide, or let's review this slide. We talked about liraglutide, semaglutide, and tirzepatide, 3 of them having the FDA approval for obesity, but we also use this medication for cardioprotection in diabetic patients, and you heard about SELECT study that shows this medication could be cardioprotective in non-diabetic people. So this medication not only are being used for treatment of obesity, they can be used for cardioprotection in people with type 2 diabetes and established ASCVD. And 3 of the medication, they have liraglutide, semaglutide, dulaglutide, which is a brand name of Trulicity, Victoza, and Ozempic for diabetes treatment. They have indication for cardioprotection. And technically, dulaglutide is the only one that has indication for cardioprotection in people who are at high risk for primary prevention. But we have other trials ongoing for cardioprotective effect of this other medication that don't have indication yet. We have SOUL trial that we are closing. It's close to finish line, and we should hear the result very soon, maybe in the next big meeting, that whether oral semaglutide also is as protective as sub-Q semaglutide in reducing MACE. You saw, I think Dr. Hani was the one that showed Pioneer and also Sustain 6. It happened that Sustain 6 showed protection in regard to cardiovascular disease, which is sub-Q semaglutide. But Pioneer, that was oral semaglutide, did not show cardioprotection. Both Sustain 6 and Pioneer were powered for non-inferiority, but it happened that Sustain 6 showed superiority. So FDA didn't force them to do another trial, but they force them, if you want indication for oral semaglutide, you have to do a large trial powered for superiority. That's why SOUL is ongoing right now. And SURPASS CVOT, we're going to close the trial in the next 2-3 months by the end of the year. So next year, we're going to hear whether tirzepatide is also cardioprotective and can reduce the MACE events. And in regard to non-diabetic people, we have SELECT trial, and also we have SURMOUNT MMO. So testing tirzepatide in non-diabetic people, can it reduce cardiovascular event, and also they look at other comorbidities as a secondary outcome. So another table, I know that the next session in the afternoon, we're going to talk a lot about non-glucose lowering, non-weight loss effect of this medication, but I thought I kind of start this segue as a segue to kind of tell you what we have and what we are studying. It was briefly mentioned that semaglutide has been tested in people with HFpEF, with or without diabetes. We have a step-HFrEF and a step-HFrEF diabetes, and it improved symptom and function. So the primary endpoint for a STEP trial was Kansas City questionnaire. People filled out the questionnaire, and they talked about their symptom, okay? And it improved those as a primary endpoint, both in people with diabetes and without diabetes. Tirzepatide also has the same trial, SUMMIT trial, that tested whether tirzepatide can improve. Actually, they went for hard outcome, hospitalization for heart failure in people with HFpEF and with or without diabetes. And this one has been released as a news release. We don't have the paper, but it decreased events. So tirzepatide is super exciting time that tirzepatide also can reduce heart failure in HFpEF people, but I haven't seen the data yet. CKD with people with diabetes, FLOW study showed that semaglutide can reduce kidney composite endpoint, which was multiple endpoint in people with CKD and diabetes. Usually this endpoint includes mortality, reduction in EGFR by either 40 or 50%, depending on what study you look at, and end-stage renal failure. This composite endpoint was reduced after semaglutide, and this is one of the few studies that we have seen in our time that it was stopped prematurely because it was not ethical to continue the study. We found out, or DSMB found out that, hey, look like semaglutide is protecting people and reducing kidney outcomes, so why we continue is not ethical. So FLOW was stopped prematurely before the expected endpoint time. So TREASURE CKD is another one. Tirzepatide is ongoing, just started. Tirzepatide is also looking for other comorbidity, whether, for example, tirzepatide can reduce the symptom of OSA, and they look at specifically at acute hypoxic index, the number of time during night people become hypoxic, and the outcome just released in ADA, so it was published in New England in June, and it showed that tirzepatide, it also improves OSA outcome. PAD is another one, my area of interest, that again, people with PAD and symptoms, we really don't have that many medication to improve symptoms in PAD. But the STRIDE trial, we just completed, data has been analyzed, and it's going to be presented in the next big meetings to be determined. I'm not supposed to disclose. But this one also evaluating effect of semaglutide in people with diabetes and functional symptom, and the outcome is, again, symptom, is not hard outcome. MAFL trial, we have both phase 3 in semaglutide and tirzepatide, and they are ongoing, but the phase 2 are showing, in both compounds showing some improvement in fatty liver. And the newest part is, again, the last but not the least, is this neuroprotective effect of GLP-1. Nobody knows exactly how they do it, but there has been some preliminary outcome starting with animal studies and then from the human studies, like in some of the soul, for example. We are doing all the questionnaire in regard to mental status, and look like there is some hint that GLP-1 can be neuroprotective. So there are studies going on effect of GLP-1 in Alzheimer. And if you remember, I cannot quote you what paper, what journal was it, but I think it was New England that published a paper on exenatide and Parkinson, that exenatide, a short-acting GLP-1, improves symptom of Parkinson. And that was, again, suggestive of neuroprotective effect of this class of medication. So what we are seeing is not only weight loss. I mean, these medications were first worked on for treatment of diabetes. We found that they cause weight loss. But now we are finding that beyond weight loss, when they do meditation analysis, they find that all of this effect is beyond the weight loss. So this medication may do something on top of the weight loss, whether it's anti-inflammatory. They see some benefit in other organs. So in summary, NuSH-based therapies are effective, safe glycemic lowering medication, but it also associated with weight loss. So if we kind of think about it differently, that weight is the root cause of all of this metabolic problem, so maybe it's very important to use all of this medication just for the weight loss indication to prevent all the future complications. But it happened that in people who have cardiovascular disease or kidney disease, they can be cardioprotective, or they can reduce the CKD endpoint. But you saw data from your country that only 13% of people who are indicated to use this medication are using. We have exactly the same problem in the US. I will say in the US, the data is also less than 20%, less than 1 out of 5 people who has indication, who has established ASCVD is put on this medication. So what are the problems? Why is that? I think number one problem is cost. I mean, ultimately, if you have to choose between utility bill and medication, you have to choose. And if insurance, we don't have good coverage, that will be a huge problem. So we need to approach this both from payer side and also hopefully with newer technology or increasing the demand, the pharma also lower the cost. Provider inertia. I mean, it's not only endocrinologists who are supposed to prescribe this medication. We have to fight this all together. I like the way that Dr. Hani mentioned in COVID, all of us became COVID doc. Now is the time that for all of us to become obese doctors and not be scared of prescribing a medication that potentially can lower hypoglycemia, lower blood sugar and cause hypoglycemia. And the reason I'm saying it, because when there was a paper that they gave questionnaire to cardiologists, why you're not prescribing GLP-1, why you're not prescribing medication that can be cardioprotective, and number one barrier, they said, we are scared of dealing with diabetes medication. Cardiologists don't like to deal with sugar, obviously. So injection, is injection a problem? It could be, but most of my patients, when we talk to them about once a week injection, is not a huge problem. But I talked to you about oral preparation in pipeline that hopefully can be effective and safe. Tolerability, that's a huge problem in practice. There are people that cannot tolerate it and they have severe GI side effects. We try to deal with them with diet modification, slower titration, some anti-emetic, but ultimately you end up with people who cannot tolerate it. So hopefully we might have newer generation of this medication that have less effect here on the central nervous system and less nausea effect for people to tolerate it. So I guess as my kind of couple of last statement, we need significant cost reduction. I think these are important because we are not living in utopia that we have access to this medication. We have to kind of have them readily available if it's like penicillin to kill infection. And personalized medicine, I think that's the future. I mean, not everybody respond, not everybody can tolerate, so it will be ideal if we can predict who is the responder, who can tolerate it better. And again, I think these medications are the future of obesity treatment, and obesity is the root cause of all of these cardiometabolic diseases. I think that was my last slide, and I'm ready for questions.